Good evening, everyone. On behalf of the staff at Brisbane North PHN and Queensland Health's Cancer Screening Unit, we would like to welcome you all here this evening. And thank you for taking up this opportunity to participate in the Get Ready Open Access Self-Collection for Cervical Screening webinar. My name's Amy Hoard. I'm your host for this evening, and you'll see online are a few of our speakers who I'll introduce you to shortly. But first, I'd like to begin by acknowledging the traditional custodians of all the lands on which we're meeting this evening and pay my respects to elders past, present and emerging, and also acknowledge any Aboriginal and Torres Strait Islander people tuning in this evening. And just for all of your knowledge, we've got over 100 people tuning in tonight, and it's not just our Brisbane North PHN practices. We've got practices from Brisbane South PHN and Gold Coast PHN. So that's a big welcome to everyone. And we hope you enjoyed tonight's presentation. So to ensure you get the most out of tonight's session, you should see down the bottom of your screen a Q&A box. Our amazing moderator, Marie, who's on the line, will be moderating this chat box and asking questions on your behalf for the speakers. And to make sure the night's short and quick, we're finishing at 7 p.m. And for those who are unable to attend, we'll have a recording made available. And once the session has ended, if you could provide feedback on tonight's presentation, we'd really appreciate it. So here's our agenda, and as you can see, we have 3 speakers. Our first 2 speakers are from Queensland Health's Cancer Screening Unit, and their presentation will be titled Public Cervix Announcement. So they'll talk to the changes to the National Cancer Screening Program guidelines, the eligibility criteria, role of health professionals, and much more. And then our Brisbane North PHN speaker, Michelle, will introduce cervical screening, self-collection and QI into your practice. And she'll talk to the enablers, of which is accreditation, PIP-QI, using the National Cancer Screening Register Healthcare Provider Portal. So GPs and nurses should stay tuned for that, because Michelle will let you know which clinical information softwares are now integrated, which is an exciting new development. And then also she'll show you how to identify eligible patients using a software. And then at the end, we'll do an evaluation and summary of tonight's presentations. So without further ado, I'd like to introduce you all to our first speakers, Jenny Harsager and Dr. Alice Sykes. So Jenny is a Senior Project Officer working in the Cancer Screening Unit at Queensland Health. She's originally from the United States, where she worked in HIV prevention and women's reproductive health. She's currently working on the Queensland Health Preparations for Open Access Self-Collection for Cervical Screening. And Dr. Alice Sykes is a public health registrar, currently working with the Cancer Screening Unit as well. She originally is from England, where she trained in anaesthetics and intensive care before she moved to Australia and started working in public health. She has a particular interest in preventative health and is currently working on the changes to the self-collection criteria for cervical screening. So over to you, Jenny and Alice.
Lovely, thanks, Amy. We're looking forward to speaking with you tonight about the upcoming changes to self-collection for cervical screening to make it more widely available for more Queensland women. Alice and I will be trading off a bit in our speakers, so we'll go through a few slides and then trade off. If there's any questions that come up that are urgent, let us know and we'd be happy to answer those for you. Next slide. So to give you an overview of the program guidelines, there's currently a 5-year primary human papillomavirus HPV testing with partial genotyping and a liquid-based cytology triage for people with a cervix aged 25 to 74. So this program has replaced what used to be known as a pap smear. Now we call that a cervical screen. The absence of cervical oncogenic HPV infection is associated with an exceedingly low risk for development of cervical cancer within the next 5 years. So we know that this program works on its current schedule and that it's a safe screening interval for women. So what we're talking to you about tonight is that guidelines are changing as of the 1st of July 2022 to open self-collection as an option to all Queensland women for cervical screening. So previously we had more restrictive guidelines on who could access self-collection, and as we'll go into later, there has not been great uptake of self-collection because of that. Next slide. So why are we so excited about self-collection? And we do think that this is going to be a game changer for Queensland women. There has been extensive research supporting a change to open access self-collection, both nationally and here in Queensland. In national research, self-collection as a test has been shown as to be reliable for finding high-risk HPV, just as reliable as a traditional screen. However, currently, program participation is poor. Up to 40% of Queensland women are not screening using the national program. And so we do know that even under the current every 5-year program, that there are barriers for women to screening. This year, CSU, or the Cancer Screening Unit, conducted qualitative research with lapsed and never screened women to identify why women do not participate and to explore the acceptability of self-collection as an alternative to those women. Next slide. When we looked at underscreened women, we know by our research and national research that there are a number of women who are likely to be underscreened. They might be from younger age groups, they might be from Aboriginal Torres Strait Islander or CALD communities. They might be communities that are affected by social and economic disadvantage. Although the cervical screen itself is free, women may have trouble accessing a bulk bill GP provider and may be averse to having a payment for this screen. We do know that there are very personal reasons why some women do not want to have a traditional speculum exam and test. Women who have experienced sexual assault or had a poor experience with a previous exam probably are not going to want to have another exam. Women in LGBTIQ communities their GPs may have have a poor idea of whether or not they are eligible for screening, or they themselves might not know about their eligibility. And we do know that there are physical barriers as well with people who have disabilities or people who are very overweight. Next slide. So some of our key findings that we found with our research with under and never screened women is there are knowledge gaps. Women didn't understand the current program, when they were eligible, whether or not they needed to have it, if they had already had an HPV vaccination, if they hadn't been sexually active for a while. Those were the kind of things that gave them the impression that they might not need a cervical screen. Also, as I stated in the previous slide, some women have just had a very poor experience of screening, pap smears, or other personal exams and don't want to have an experience like that again. We found, interestingly, that the role of GPs was both a barrier and an enabler to women's experience of screening, and that women both felt uncomfortable seeing a GP that they have a great relationship with for screening, and feel uncomfortable also with a GP that they don't have a good relationship with for screening. So it's just something where women don't exactly feel comfortable in that space. Regarding self-collection, women said they would like to see it widely available after we told them about it, and that's key. All the women in that survey were currently eligible for self-collection based on being overdue or never screened, but they hadn't heard about it. Once they heard about it, they said, this would be a great way for me to screen. I just want to make sure that I'm doing it correctly. And they also were interested in an at-home option, though that is not currently what's being offered with open access self-collection. Next slide. In research that University of Melbourne did with healthcare providers about self-collection, and this is under the old guidelines, they found varying support amongst primary care workers for the self-collect option. Practitioners and pathology sector folks we found had misconceptions about self-collection, mostly around its accuracy for finding HPV. Clinicians wanted the conventional collection method to remain the standard, and that's often because women come to see you for a variety of reasons, not just a cervical screen for HPV, and that physical exam obviously can find other things. They felt that clear and consistent guidelines were needed. Under the original guidelines that went out about self-collection, there were questions about whether or not you had to observe directly a woman taking her screen, and practitioners felt confused by that. So they wanted clear guidelines, and they want education and tools for guidelines for clients, and those are being worked on right now. So also very important is consultation occurring with practice management software companies. As we know, if you can't put it in your electronic records, then you're going to have a difficult time following up. So those are also conversations that are happening at a national level, and I know that Brisbane North is going to address that in what they're saying. So I'll hand over to Alice and move on to the next slide. Thanks.
Thanks, Jenny. So I'm going to start by talking a little bit about self-collection. So the self-collection sample itself is taken from the vagina. It's a low vaginal sample. It's not taken from the cervix, and then it's tested for the presence of cervical HPV. And the reason that these changes have come around from the 1st of July is we have a lot of evidence and a recent meta-analysis which showed that these self-collected vaginal samples taken by women themselves are as accurate at finding HPV as a clinician collected sample that's taken from the cervix during your speculum examination, and also as accurate as finding SIN2 plus cancers as well. So next slide, please. So as Jenny was saying earlier, the self-collection is actually available under the current guidelines. But we do know that less than 1% of women who are tested under the cervical screening program in Queensland actually are tested using self-collection. And part of this is the eligibility criteria are just a little bit stricter at the moment. So at the moment, you need to be asymptomatic, so have no symptoms of cervical cancer. You need to be over 30 years old and either be never screened or overdue by at least 2 years in order to be eligible for self-collection. And that is up until the 30th of June this year. So only for another couple of weeks, but up until the 30th of June, those are the eligibility criteria. Next slide, please. So from the 1st of July, these eligibility criteria are really opening right up. So you still need to be asymptomatic, and that's because there is the different guidelines which require a co-test for women who are symptomatic, because they will need cytology, and obviously we can't do that with self-collection. But everyone else, everyone from the ages of 25 to 74 who is eligible for cervical screening, so all people with a cervix, are eligible for the choice between self-collection or a clinician collected sample. Healthcare professionals are not required to observe the patient collecting that sample, and it can be done behind a curtain in the room or taken off to do at a bathroom. And there is even a provision in the guidelines that if a healthcare provider feels it really is appropriate, that woman could even take it home, depending on the type of pathology company you're using. Next slide, please. So this is looking at the pathway for self-collection. So once a woman has taken their self-collected sample, obviously they will then get the results back. So there's really three main options. The first option is that they're not HPV is not detected, in which case they would rescreen in 5 years, and then that point they could have another self-collected sample if they wish. Another option is that it's positive for HPV, but type 16 or 18. And we know at the moment this is approximately 2% of women who are tested in the cervical screening program come back as positive for type 16 or 18. And if that's the case with self-collection, then that would be the point that you would refer straight for colposcopy. So these women do not need to come back for a speculum examination LBC, because the LBC can be collected at colposcopy. However, if they test positive for an HPV not 16 or 18, then that would be when you'd need to invite them back to have a healthcare provider collected sample for an LBC. And depending on the results of the LBC is where you would go to next. So if that LBC is negative or low grade, then they would return in 12 months for HPV testing. And if it's high grade or has a glandular abnormality, then you'd refer for colposcopy. I'll just take the moment to say it's really important that you label the sample that you collect as self-collected, as that kind of changes how they use it at the laboratory. So it's a red cap top. It's a dry swab currently, and if it's not labelled as self-collected, it can cause issues if it's tested for cytology, as the vaginal squamous cells look very similar to cervical cells, and it can come back with a false negative as cytology. So it's really important that it's labelled as self-collected. There's an option as well when you are collecting the sample, so women can collect it themselves. As a self-collected sample in the bathroom or behind a curtain, or if they are really resistant to having a speculum examination or are unable for some reason to do the self-collection themselves for physical reasons, or if they're worried about not doing it properly, as a healthcare provider, you can actually do the vaginal sample yourself and label it as self-collected and do it that way. Next slide, please. So there's very much still a role for healthcare professionals in cervical screening with self-collection. This isn't like the bowel screening program. We're not going to be sending out kits. There is still a need for an appointment with a healthcare provider. As people who know your patients best, you're going to be the people who are using your clinical judgment and talking to women about the options. So it's an option between self-collection and clinician collected. And obviously there's pros and cons to both. And women need to understand that there are possibility that they may need to come back in for follow-up with a speculum examination or colposcopy. And it's important to talk to them about that when they're making that decision between a self-collected sample or a clinician-collected sample. Obviously, when you're doing the consultation, that's the point where you'd also be explaining how to collect the sample themselves. And there's some good resources out there. It's very similar to how you would collect an STI self-collection at the moment. So the same resources can be used to explain it to women. Next slide, please. So there is quite a number of free education modules out there, as you can see here, and we will share these details with you. They're worth up to 40 CPD points, RACGP points. So, and as I said, they're free. So a really good opportunity to learn a bit more about self-collection and increase your GP points. Always a good selling point. So I'll hand back to Jenny. Next slide, please.
I just will hop in here with a little question or two.
Go ahead.
So we've got a question from Sharon. Are the tubes for collected and practitioner collected, for self-collected and practitioner collected different? And then if different, why is it going to be so confusing for the pathology company if not labelled as self-collected? Maybe that's if different, why is it going to be so confusing for the pathology company if not labelled as self-collected?
So the label for the self-collection is just so that because they are receiving just a swab, they need to know what you've taken, because they will test both for cytology, and obviously you don't want to come back with and they can't tell because the cells are so similar. So you don't want to come back with a negative cytology on a self-collected sample, because that will give you the impression they've had an LBC when they haven't.
One of the things that we're anticipating also is new testing technologies coming on board. So while currently, if you're going to do a thin prep collection, that would go into a vial and go off to the laboratory, and you would assume that that was a traditional cervical collection. What we anticipate is going to be happening is that new laboratories that are coming on board to begin to offer self-collection pathology are using a different system than the current dry swab collection, and that swab needs to be also swirled in a thin prep type vial. So we're just trying to, trying to hit home that the proper labeling needs to be done on each lab collection because of those myriad of technologies that might be coming forth with different types of swabs.
Okay, and Jenny,
Thanks.
just following on from that, there's, I think what you've just said would explain a follow-up question from Sharon, which is, why won't the pathology company recognise it as self-collected?
Yeah, and I think that's it, though. We're from our conversations with pathology companies, trying to follow their instructions, which is that they want to make sure that they know what they're getting, and that they're not getting something that's self-collected that comes to them looking like it's a traditional collection.
Okay. And there's one last one, just for now. Is it acceptable to revert to vaginal swab if unable to reach cervical Oz with difficult collections?
Yeah, I don't know if Alice wants to say anything more about that. And I didn't mention this earlier in our slide, but we have also looked at this as this new technology as being a game changer for women who might be postmenopausal and have cervical stenosis. So I think that this will be an option that you can use when you cannot get a sample. Now, just realize that you aren't going to get that LBC. Did you have anything more to add about that, Alice?
No, so that's fine. And as I said before, it would just count as long as you label it self-collected. You can do it for women who are postmenopausal, or women who say due to body habitus or a physical disability are unable to do the vaginal sample themselves, but you are for some reason unable, or they don't want a speculum examination. You can take that as the clinician, do the vaginal sample yourself, just label it as self-collected, so it's really clear that it's a self-collected sample and they're only testing for HPV, not cytology.
Thank you.
Great, thank you. All right, moving on, we did want to just have a little bit of a discussion about sexual health conversations, because we do realize with cervical screening that there, usually is a accompanying conversation about sexual health, and a cervical screening or contraceptive consult provides an opportunity to talk about sexual health and STI testing. So we just want to reassure healthcare providers that they are considered approachable to discuss sexual health and to understand the issues facing sexually active Queenslanders. And as from our the key age groups that we're looking for with cervical screening, I know that we're looking at a wide age group of 25 to 74, and you might think about those conversations as being geared more towards the younger age groups, especially when we're talking about things like chlamydia and gonorrhea. But we do realize that these are becoming increasing problems in older age groups, sexually transmitted infections, and it's always good to at least have that conversation with your patients. So most people would prefer to consult with healthcare providers who provide positive advice about being sexually active rather than focusing on just risk behavior. So knowing that most people are sexually active, and some people have riskier behaviors than others, but normalizing that behavior. Migrants or called people have also indicated that it's okay to offer STI and BBV testing opportunistically during an appointment, so they don't have to come in just for that you can refer them on for screening when appropriate. Next slide. So most people are happy to talk about sexual health and STI testing, but they are not necessarily going to bring it up themselves. There was a study done in Perth that found that patients were not embarrassed if a discussion was initiated in a consultation unrelated to sexual health. So somebody might come in for their annual bloods, and you can say, is there anything that we need to talk about with sexual health or STI screening? Patients felt comfortable discussing STIs with their GP, and their level of comfort would be enhanced if they knew that their GP was especially interested in it or had a qualification in sexual health. Not every GP does, but acting as if you're interested can help. And there are tools available via the health.qld.gov.au website. And there's a number of different versions for talking to asymptomatic people about sexual health, depending on how much you want to go into that. Next slide. And again, as Alice stated, there is vaginal sampling that happens for gonorrhea and chlamydia via self-collection. We have a diagram here which shows that process with a woman in a bathroom. Again, when we're talking about cervical screening, that might happen behind a curtain in an exam room. It really just depends on your clinic flow and where you'd like to have that done. The WHO recommends that a self-collected sample for chlamydia and gonorrhea should be made available as an additional approach to deliver STI services. So again, within this context, the self-collected sample is valuable. And however, for chlamydia and gonorrhea, a vaginal swab is more sensitive than a urethral first pass urine and is the specimen of choice. And there are more comprehensive guidelines available on the STI management guidelines for use in primary care, remembering that not all STIs are symptomatic. Next slide. And there's a few conversation starters that are recommended also. For instance, while you're here for cervical screening, it's a good time to talk about other areas of sexual health, like having a sexual health checkup. Is that applicable to you? For younger folks, you might talk about how common STIs are, especially chlamydia. Is it time to test today? During a general health conversation, while you're here, we offer STI tests. Is that appropriate to you? Travel consultations might be back on the table, I guess, now, where you can talk about STI rates in other countries if people are coming in for vaccination or advice about travel. And also just a reminder to talk to your patients about hepatitis B vaccination and the protective factor there. Next slide. All right, lovely. And I'm going to pass back over to Alice to just give a couple of areas of wrap up.
Thanks, Jenny. So as an overview about what we've been speaking about this evening, so the guidelines change from the 1st of July. And they open up self-collection as an option to all Queensland people with a cervix who are eligible for cervical screening. So everyone with a cervix between the ages of 25 and 74 who doesn't require a co-test can have self-collection. It's a low vaginal sample, and it's collected with the supervision of a healthcare provider. And really that just means that they do require a healthcare provider appointment, and they can then go behind a screen to the bathroom, or even at home if you feel that's appropriate. It's an opportunity to discuss other screening. The time that you save in not having to do the speculum examination can be used to discuss STI screening or any other appropriate health issues. Women are not eligible if they're symptomatic for cervical cancer. That's because they require cytology. That's a different set of guidelines, and they are not suitable for self-collection if that's the case. Just a reminder that when you are offering self-collection to women, it is important that they know about the follow-up, and if they are HPV positive for non-16 or 18, they will need to return and have a speculum examination and an LBC collected. And again, just a reminder, it's really important to label that swab as self-collected when you're sending it on the pathology form, so that the labs know that it's a self-collected sample and not clinician-collected sample. People can send in the wrong swabs for, say, clinician collected or self-collected, and if they've got it on the pathology request form, then they at least know it's supposed to be a self-collected sample. Next slide, please. So how to get started with self-collection. So discuss it at the clinic level. How's it going to work in your clinic flow? I've spoken to a number of GP surgeries who are going to be doing it behind a curtain, who some say, oh, we'll send them off to the toilet. We've got posters on the back of the toilet doors on how to do self-collection for women. I've spoken to some who've decided that they're going to do an entirely separate women's health room where women can go. So how is it going to work for you? How is it going to fit into your everyday appointments? And you need to continue to identify under and never screened women so that they can be offered self-collection. Because up until July the 1st, they are the only people who are going to be eligible, but also because we think this is going to be something that under and never screened women are really going to be interested in, as you heard from our research that's been done by the Cancer Screening Unit. It's important that you ensure that you have enough self-collection kits to meet demand. We expect that women will, once they find out about it, will be coming in and asking for self-collection. The communication to the general public may not come around until later this year, but from the 1st of July, you may get women coming in and asking for self-collection. So really important that you're able to do that for them if they want to. Currently, there are only 3 pathology companies that do testing for self-collection themselves, but other companies will send through any self-collection kits and things that they receive. So SMP, VCS, and a third one whose name currently escapes me are the only 3 that actually do the testing. But pathology labs like Foresight and QML, you can order the kits from them and send them back through them, and they will send on the kits. As Jenny mentioned earlier, there is going to be a bit of a change. So although currently there's only 3 labs that are accredited to do self-collection testing, other labs are coming on board with a slightly different technique. So if you are with, say, Foresight or QML, you may find that later on in the year, they tell you that you need to change the swab you're using or the process that you're using to do your self-collection, and it may mean that you need to swell it into a medium immediately after collection rather than the dry swab which you're currently using. So just bear that in mind and keep in touch with the pathology companies. Again, I know we keep saying this, but really important to label it as a self-collected sample. Even if you're taking it as the clinician as a vaginal sample, even if you've taken it, it's still a self-collected sample if it's from the vagina, not the cervix. We do have lots of resources for GPs and patients on the Queensland Health website, so please do check those out. There's lots of social media, and we're working on some resources that you can hand out to women to remind them about the follow-up for self-collection, and a bit of information on self-collection itself. As I mentioned earlier, we've got some free education modules that are available for GPs and practice nurses, so please do make use of them. And just a reminder that the guidelines come the 1st of July, will be up on the Brisbane North health pathways. So you can take a look at them. At the moment, they are available on the Cancer Council website. And there is a small PDF at the top for the updated guidelines, which will change over on the 1st of July. And I think that's it for me. Is there anything else you'd like to add, Jenny?
No, that sounds good. But if there are additional questions about pathology, we're happy to answer those as well. It's just a little bit of a changing space at the moment.
Well, speaking of questions, there are a few here. So I've got 4 more to ask. The first one is why the specific reference to Queensland aren't the changes national. And I believe that one came in around the time we were talking about the sexual health. So yes, the cervical screening changes are national. And
yeah, I think that the only thing that I'd add to that is that, yes, the changes are national, but we do know that Queensland in particular has had really low uptake of self-collection. We have seen a little bit better uptake in states such as Victoria, and they have a very active lab in the Victoria Cytology Service that has really been encouraging self-collect there, and they've done a couple of pilot projects with telehealth. And then we also know, because of our remoteness in Queensland and a large population of Aboriginal and Torres Strait Islanders, that this is really going to be an essential technology for us here in Queensland. Thanks.
Excellent, thank you. I hope that answered Anonymous's question. The next one is, can a self-collected test be offered via telephone consult, or does it require a face-to-face appointment?
As Alice said earlier, it does not require a face-to-face appointment, though depending on the technology that your laboratory uses at the time that you offer the self-collection, you will need to do a telehealth appointment. And the Roche lab system, which will be adopted by QML and a few other laboratories, is not going to be able to be done outside of the clinic setting because of needing to be swirled into a liquid medium. So to be clear, that technology is not yet out, but we're looking at just a matter of months here before that is also an available technology, depending on who your lab is.
Okay. The next one is, some women who are under or never HPV screened are women who have had a hysterectomy. Can they do self-collection?
So you can self-collect on anyone who doesn't require a co-test. So if they need a co-test for any reason, so if they need cytology at the same time for any reason, then no, you can't do self-collection. But if it's just an HPV test needed at that time, then yes, you can do a self-collect sample.
Thank you. This might be similar. What are the recommendations? Are there changes for vaginal vault smear?
No, I'd say that's a separate test.
Okay. And then finally, are there posters we can order or print for our clinic toilet on self-collection? I know there are some available sexual health-wise. There's that chlamydia screening one, but is that one of the resources available for the cervical screening?
Unfortunately, not yet. We are waiting on the national resources that are coming out, which will have that availability of a nice kind of poster that you can put inside of a toilet that'll show the process for self-collection. So we're waiting on that to come out, hopefully in the next couple of weeks, and we will let the PHN know when those are available.
If we let people know where or sent the link for the ones that we use for the chlamydia, gonorrhea.
Yeah.
That would be okay in the meantime?
Yeah, that's okay in the meantime.
Beautiful, thank you.
Thanks.
That's all from me for now. Thank you.
Thank you, Jenny and Alice and Marie. So for our final speaker this evening, I'd like to introduce you to Michelle Casella. And Michelle is our Quality Improvement and Development Engagement Officer at the PHN. She's been with the organisation for over 14 years. So that's from divisions to Medicare locals to now what's known as Brisbane North PHN. And she's worked on a number of quality improvement initiatives such as the Australian Primary Care Collaboratives, CVC Coordinated Veterans Care Program, and many other health preventative and chronic condition projects. And basically, to sum up Michelle, she's just passionate about all things quality improvement. And I'd also just like to apologise to our audience. We do have a smart screen here tonight, so sometimes it jumps ahead. That's not us, and we'll try and revert it back. So if you're trying to follow along with the slides and they do change, we do apologise. So over to you, Michelle.
Oh, thank you, Amy, and good evening, everyone. Leading on from Jenny and Alice's presentation, I will share on how cervical screening self-collection can be introduced and implemented into the practice under the scope of accreditation and quality improvement. But what we want to do is, before I begin my presentation, if we can take a quick poll so we can understand the audience and how the slides might relate to you. So 3 quick questions.
Wow, it looks like we've got mostly GPs on the line. That's interesting. And 100% of you have answered, oh no, 94 now are an accredited general practice. 67 are participating in the practice incentive payment for quality improvement. We'll give you a couple more seconds, hey Michelle, and then I think I should be able to launch the results so you guys can have a squiz.
Well, for practice managers, I'll go through the practice-based enablers to support you in focusing on cervical screening as part of your QI. And for the GPs and practice nurses, I'll talk to the National Cancer Screening Register, the NCSR, Healthcare Provider Portal, and the interoperability with some of the clinical software used in general practice. So, what are the practice-based enablers that support cervical screening? Essentially the why for focusing your efforts on cervical screening self-collection. If you are an accredited general practice under the RACGP standards, 5th edition, you would be aware of the criterion QI 1.1, which is your quality improvement activities, and also familiar with the key indicators of this criterion. So when implementing a QI activity, you bring in your dedicated QI staff member or members, develop the process for, in this instance, cervical screening activity, and then share the process with the practice team. What works, what doesn't, and how to do better. Documenting what your practice has improved on in the past 3 years by doing your QI activities. A lot of you will be familiar with the PIP-QI. So this is an incentive payment to general practice for participation and quality improvement. And by focusing on cervical screening self-collection as a QI activity, this is going to be meeting your PIP payment. Each PHN has a different support model, and at Brisbane North PHN, we've got 3 dedicated QI engagement and development officers available to support your practice with this task. Next one. So, as part of PIP-QI, a set of 10 quality improvement measures have been developed by the department and adapted for broader use across all general practices. These 10 measures support a regional and national understanding of chronic disease management in areas of high need. And one of the QIMs, Measure 9, refers to the proportion of female patients with an up-to-date cervical screening. Next slide. So to get a better understanding on how your practice is tracking in terms of data quality, Here at Brisbane North PHN, we supply your practice with several quarterly health data reports built from the de-identified data shared. And amongst these reports, 2 pertain to cancer screening. The 10 QINs, the report QIN 9, identifying the percentage patients of up-to-date cervical screening, and the cancer screening report, which identifies a number of possible QI activities to action. All this data is presented in these reports and are searchable in your practice to identify the patient worksheets from the CAT 4. Now, the exciting news to share with our general practices, if not aware already. GPs and practice nurses, you now can have access to check your patient's screening information and program status, to update your patient details and more. One of the time-saving benefits by having access and utilising this process is that GP or practice nurse can search for a patient, view their test results and screening histories with an option to print, the report. Now, that's a great QI activity to capture those missing screenings and enabling you to now have them in your patient's clinical records. The National Cancer Screening Register Healthcare Provider Portal is a single electronic record for each person in Australia participating in cervical and bowel screening. The Healthcare Provider Portal is now integrated with Best Practice, Medical Director, and Communicare. If you have not yet installed the integrator to work with in any of these softwares, please consider. I can testify I have only had positive feedback from the GPs that are accessing the NCSR. If you are looking for support installing it, please contact your software provider. So here is a snapshot of the NCSR that's integrated with Medical Director and Best Practice. Once you've enabled this within your clinical software, Medical Director allows the access from the widgets section, and whereas Best Practices view is accessible via the View tab and the NCSR Hub. MD and BP both have user guides to support with this process. This snapshot is from the cancer screening report provided by the Brisbane North PHN. I want to demonstrate an easy QI activity relating to the cervical screening. Who of the eligible patients have not had a cervical cancer screening? So to do a search for your active patients between the 25 and 74 years of age who have not had a screening noted from the practice report. This search can be performed in a number of ways using your CAT 4, primary sense, polar. Remember again, your PHN can support you with this process. So if we can go to, we're not using the active searching tonight. So we've taken some screenshots. If we've opened up the CAT 4, we've gone to our extracts and we've filtered down, we click on our filters to go general. And then if we come across to where the age selection is, and we would type in 25 start age and end age 74. The next filtering would be your active 3 times in 2 years. The RACGP classes a patient who's been to the practice 3 times in 2 years as active, but you can also choose any, and that will bring any patient who's attended the practice. And then lastly, we would go to the very top right-hand corner, recalculate. This bringing across our report. To get a better aspect of what we're looking at, we would hide the filtering process and we would then go to our screening tab, look at our cervical screening graph, and then we would click on either in the legend, not recorded, or you can actually click on the graph itself, not recorded. Then the next component would be that you would export that. And lastly, that would bring up your identified patients. In this, because we're looking at de-identified data, we can't see anyone. But when you're in practice, you'd have all your patients noted. You would be seeing that we're filtering by the age of 25 to 74, our active patients, and cervical screening not recorded. This count says 589 for this practice. You also can note that it would either say not recorded, or you do get an option to see if the screening date is in a past instance. This is where you would take your report to the GP to discuss the next steps and how to engage with any patients identified to be either recalled or invited for an overdue screening. Appreciating that not all patients may have had their cervical screening performed at the practice, this is again where you have access to the NCSR, the National Cancer Screening Register, and that's so beneficial. You'd be able to do a search to see if the screening has been done elsewhere before you contact your patient for recall. Finally, a thought for the practice. If you have identified any patients who might fit that eligibility criteria for appropriate NBS filling for overdue screening, this should be considered. If you are in our region here at Brisbane North PHN, I speak on behalf of my QI colleagues, Jo, Leanne, and myself, and Donna. We are here to support you, so please do not hesitate to contact us via practice support. For anyone else located in other regions, our fellow PHN colleagues are also wanting to support you and your practices. So please reach out to them for any follow-up on what has been shared tonight. Thank you.
Marie, do we have any questions that we should address?
We do. This one's, does the search rely on practitioners entering CSV into the correct part of the program, the clinical program, I imagine, clinical software?
It does, I'm afraid. So that's another QI activity to upskill everyone to be able to record those results into the patients, so it can be mapped through the extraction tools, be it the CAT4 or Polar.
And that could be part of that data cleansing process.
Exactly. So
with your list before.
That's where you get the QI support from the PHN. We'd love to help you.
Wonderful, thank you. That's it so far.
Great. Thanks, Michelle. That was a great presentation. So in closing, just to summarise all of the presentations tonight, it may be beneficial for your practice team to organise some self-collection training in preparation for July 1, and just also noting that we will be sharing the slides from tonight so you can access all of the links provided in the presentation when we send that follow-up email. And you may also like to arrange self-collection kits with an accredited pathology provider so you can anticipate those patients walking through your door on July 1, or opportunistically identifying patients now that are under and never screened. And also to know your practice's data. How many patients in your clinic are actually eligible for the current clinical guidelines? That might be interesting for you guys to have a look at. And of course, you can refer to your cancer screening report now in practice. I know it varies on who has access to our portal where you'd access your reports, but that's where we come in and help you to access those reports. So if you're a GP tuning in and you're not sure where that portal login is, or you don't have a practice manager, just give us a call on our support line and we can direct you in the right place. And don't forget, if you do any activities that are improving your processes in practice, that's a QI activity. So record it, whether that be in a paper form or an electronic folder that you have stored on your computer. QI activities don't have to be as big as some people think. They can be very small, and that's what we can support you with implementing. And finally, don't forget to complete the evaluation for tonight's session and let us know if an hour's session was great, or if you prefer it longer, or if you prefer for us to do them face-to-face again. We're really open to all of your feedback and we'd love to hear your thoughts. So in finishing tonight's presentation, I would like to say a big thank you to our presenters for spending their Wednesday night to talk to all of us about cervical screening self-collection, and of course to our amazing viewers for their questions and for seeing the patients. You do the biggest job. If there's anything we can help you with to support you in your process in implementing self-collection in your practice, please do reach out. And thanks again. Take care.